which means you'll get a little longer break here coming up at the 3 o'clock hour. Dr. Logsdon, can I have you come up, sir? There he comes from the back of the room. See, getting him mic'd up. So I was reading through his background, and while he's getting mic'd up, I'm gonna go forward with this. I have never known a cardiothoracic surgeon who started his career as a chemical engineer for an oil company, who also helped start a company in New Orleans that recycled wine bottles from restaurants in New Orleans and then got that glass back to them in other forms that they could use in their restaurants. So when I asked him that question a moment ago, he said, well, it's all just pipes and fluids, so it's all the same thing. So we'll see if he can explain it a little bit better than that. But coming to the stage, Dr. Logsdon, welcome, and thank you for coming in today.
Thanks for having me here. You guys have a clicker I can use?
Yep, we should have.
Excellent. Sorry about that. Hi, how are you?
All right, I'm going to explain to you again. This one is for putting people's eyes out.
Sure.
That one is for advancing.
Okay. Well, thank you for having me here. The introduction's interesting. You know, I've had a serendipitous course to where I am now. I'm the chief of cardiothoracic surgery at a program at Eisenhower Health in California. We're about 2 hours outside of LA. I trained in LA, I trained at USC. I spent 7 long, painful years there, but it crafted us into what I am today. I was an engineer before. I get it honestly, my family, we're all engineers. We're all engineers from Purdue. We all worked either at Eli Lilly or for the oil industry. And so that's where I started my career in New Orleans. And then, you know, somewhere in my first few years, I realized that I wanted to do something a little different than the family, but I wanted to kind of keep it in the same field. So the whole point about pumps, pipes, and fluid flow and valves, that's all the chemical engineering that we used to do, and now I just do it in the human body. So I'm here because what I'm going to talk about, I use every day. I'm a very busy surgeon. We've grown our program significantly, and there's just 2 of us. I'm on Q2 call almost all the time, so to get up here is extremely challenging, but I felt like it was worth it to come up and talk about our experience, so I said, sure, I'll come. You know, when it comes to healthcare, and I think we talked about physician burnout, it's extremely important to address that, but it really comes down to how are you managing the sheer volume of patients that are coming into your program. You know, in our cardiovascular center that we have at Eisenhower, we have a tremendous amount of patients. We probably take care of 60 square miles, maybe 100 square miles of people because we're literally in a desert, but we're also in a healthcare desert. And what we find when we look at our program, so I started there in 21, what we found is that we have a lot of patients that their disease processes are not identified and therefore they're not treated. And when we look across the health systems, we see that in every single health system. Who here is like runs a health system? CEO, CAO, we had some CMOs, right? You know, and so you're a little stretched away from the actual delivery of the care, but what we see in each of your systems is there's a lot of patients that go untreated. They go missed, right? And what happens is, and again, I usually give this as a healthcare talk. I don't talk a lot about the finances of healthcare. They do have to marry up, but the business of medicine is always a tough conversation because it goes from, yes, I need to deliver this care, to what does it cost to actually do this? And in this country right now, we have a big discordance between those 2 things. The cost and the delivery, the cost is skyrocketing, right? And it's making the delivery hard. But what I'll tell you is in our cardiovascular center, most of those centers deliver about 25 to 40% of a hospital revenue. People that run cardiovascular centers will see it. Does that number line up to what you're seeing? Yes, no, maybe? It's a big driver for us. Neurovascular also, neurosurgery as well as orthopedics. And so, but the reason I got involved with this is that the delayed patient identification is costing us patient lives. And so what I'm going to talk about today is that when I started in my practice, I went out to look at software solutions that could help me manage the sheer volume of patients that I'm required to oversee. We've got about 20 to 25 cardiologists in our practice. We cover about another 10 cardiologists outside of our practice that work in our hospital. We have 2 surgeons. We've got a large amount of APPs, and we probably manage over 30 to 40,000 patients in our healthcare system just with cardiovascular disease. And so, again, I usually give this to physicians. I'm usually talking to them about the delivery of care and how we can optimize that. But we're talking to executives today, and I wanted to come talk to you because you are in a driver's seat to help make decisions to eventually impact patient care. You may not be deciding what kind of care is being done, but you can help identify those patients. So key questions that sometimes executives are unable to answer. And I'll pause here because I do a lot of clinical research. And when you're a clinical research, you're always asking questions. For example, in my health system, I asked the question before I installed some of the software I'm going to talk about here in a minute. I said, how many patients in our health system die with severe aortic valve stenosis that are untreated? We couldn't answer the question. I have no idea. How many patients do I have with aortic valve stenosis, right, and a heart that's failing? I don't know. We had no insight into that. But having insight into that type of data allows you to, 1, treat the patients, 2, right, identify what your program is going to look like in the future, how many patients are actually out there. We couldn't answer it. There was no way to answer it. There's no way to look at that data. In your setting as an executive, how many guideline indicated cardiovascular patients are not moving to treatment? Do you know? How many patients stall in the care pathway, right? And for you, that's a revenue cycle generator. Predicting revenue in healthcare is challenging because I'm not sure how many patients are coming. But if you had insight into where they were in their disease process, you would know what health system you need to build to allow to have the ability to treat those patients. So 1, they don't go untreated. And at the end of the day, what I care about is they're not dying with a disease that's preventable. Another question, which patients should be prioritized now? ERs do pretty well with that, right? They do a pretty good job of triaging. We don't do that in the patient care pathway. And I'm going to specifically talk about cardiovascular because that's where I work. And then for you, how much incremental margin is left on the table? If our health systems aren't profitable, we can't expand, we can't treat more patients. So there's a lot of AI tools out there. I think our previous speaker talked about it. You know, we get pitched all the time on solutions, all the time. And there's a lot of options out there when it comes to AI. It's a very hot topic. The majority of it is all natural language processing, meaning it takes the data, helps you screen through it, and then filters it appropriately and takes actions on it. I'm sure all of you have been talked to about different solutions out there that can deliver care, and it can be a little daunting when you look at it. Where do I go? What do I pick? How do I do it? Well, when I came out of practice, I had a few good partners. One of them up at Stanford, Rahul Sharma, a very good friend of mine and kind of a mentor in this space, introduced me to the software called CardioCare by Ignite. And it helps you evaluate your cardiovascular patients. And when I got into it, I said, you know, there's a lot of options out there with CardioCare. There's a lot of options with AI that help you look at your patients. What are people saying about it? And the feedback was amazing because, again, I was looking through all these options. I was looking through all these solutions about how do I manage this large volume of patients, right? And I'm going to give you my specific hospital example, and I'm going to go into more detail. But how do I do that? And Rahul said, take a look at this. And I said, what are people saying about it? They said, you know, before CardioCare, we would see 15 patients, and only 2 or 3 of these patients would receive treatment. Now, with CardioCare, out of 15 patients, we are seeing 11 or 12 of those patients receiving treatment. What does that tell me? You're able to identify the patients that actually need treatment when they need it. You're triaging care. We have tried Epic Slicer Dicer. We have Epic at our hospital. We tried to do that to help screen these patients. Did not work for us. Similar discussion with another registered nurse navigator. CardioCare is more powerful than the Epic tool, meaning CardioCare is easy to use and easier to interpret. Very factual. We treated a patient today who, if we hadn't been proactive with CardioCare, would still be followed by a primary care physician. So CardioCare, and I'm going to go into some detail now about how it works. is a software that you install that allows you to screen every echocardiogram for patients that come into your hospital. We start there as an introduction point. When you get that data on a patient who has an echocardiogram, you get information about valvular disease. You get information about heart function. You can look at all 4 chambers of the heart and whether they're changing in size or shrinking. From that information there, we're able to go in and we're able to extract information from the medical record. And so what we do is we combine that information in the medical record with the echocardiogram data, and it gives you a starting point for every patient in your cardiovascular center. And what that allows you to do, and if you're running a cardiovascular center, you really have to look at, one, what types of patients am I treating in my cardiovascular center? And I'll break it down for you very simply. And these are also your revenue drivers. You have structural heart disease in one silo. So every one of your heart valves, right, there's a disease process that goes along with that. So you've got a silo for structural heart disease. You have a heart failure component. You have a rhythm component. And these are all the different diseases that people who have heart disease, right, it's a very broad topic. They fall inside of that. And then you have some other things like coronary artery disease. You have aneurysmal disease, right? And so where I function as a surgeon, I function in every one of those categories. But until you know what patients are in those categories, you have no insight to your practice. You have 25 cardiologists. They have a large practice. You have over 30,000 patients. You can't answer the question about what's happening to any one of those patients in those silos. You're depending on the physician managing them, who, by the way, who we heard about burnout, we heard about overwork. Things get missed routinely. And so what I currently have and how I'm using CardioCare in my system, it's working when I'm not working. So today I'm not there, but every echo that comes into that hospital is being run through this system. And those patients are being filtered into their appropriate categories. They're being run through guideline medical assessments, meaning, oh, this patient has a large gradient across this valve and that's a change. Gets flagged immediately, gets brought to our team, and we can refer them to the appropriate treatment immediately. We oftentimes know about the disease before the treating physician does. And we call them and say, hey, this patient came for an echo. The results came back to us immediately. We've screened them over here. He goes, wow, that's amazing. Thank you for letting me know. We also have patients that get screened for disease that they come into your ER, they get an echo. Oh, all right, we'll see you back. And there's zero follow-up at all. Had a lady that I called, this was last year, works at the grocery store, lives out in the high desert, so pretty far from where I am, not a huge hospital out there, not a big community of physicians, had severe aortic valve stenosis, had no idea why she was coming in with fatigue and shortness of breath, came to our hospital through a transfer, got an echo, got discharged home, never saw anybody. Popped up in our system, immediately called her primary care physician who hadn't seen her in a while, and I said, hey, this patient got flagged for this disease. Would you mind if we reach out? Yeah, happy to. So we called her. She came into our clinic. We assessed her, did the full workup, and she got a new aortic valve within 2 weeks of us diagnosing it. That disease that she has and her gradient that she had, the survival rate of patients in her category at the age of 50 is about 2 years untreated. And we found her. So CardioCare is now beginning to be used across the country. There are a lot of sites. This isn't a new entity. It's taken some time to grow, and the reason I'm here is because I have interest in making sure every patient gets treated and everybody has appropriate identification for their disease. I'm sure there's stories in the room that can tell you about things that have either gone, missed, got diagnosed late, and caused some type of issue, right? And it's no fault to the providers or to the health system. It's just the current environment we are in. We are inundated. So CardioCare being used with 77 different heart teams, 828 different facilities, currently 17.2 million patients. That's huge, right? I'd love that number to be 200 million, right? I'd love that to be in every one of your systems. And it currently has about 7.2 million echoes that are being used to help train the AI to get more and more accurate as we go along. So now's my story. This is our hospital. It is beautiful where we live. We live in, it's in Rancho Mirage, 2 hours outside of LA, like I said. I started in 21, and we had a program that was doing probably about 120 heart surgeries a year. We were doing about 130 transcatheter aortic valves, maybe a little less actually, probably about 115. We'll talk about where we are today, but we're up to about 290 just aortic valve treatments now. And that's really since I started in 21. And there's just 2 of us plus some cardiologists doing the work. Our hospital is 463 beds, so it's a larger hospital. We've got some expanded facilities, but we are a community hospital. We are not run by a large organization. I know we've got some large organizations here. I saw the list of people here. And so we have a large community impact, but we don't work at a health system where we could implement something like this and impact millions and millions of lives. So you that are here, Tenet, HCA, other Dignity, those programs, if you would implement something like this system-wide, the impact to patients across the entire US would be something like we've never seen. And then on the financial side, which again, I don't talk about, your ability to drive revenue through this, and I'll show you our experience, has been tremendous because you have to marry the 2 up. If anything that you go to evaluate in terms of an AI solution doesn't add to your bottom line, it's really hard to implement because it's a cost. So, so how we use CardioCare. So CardioCare gives you a couple things at your system. One, it allows you to identify the patients in your program, right? And allows you to help manage those patients. What do I mean by that? Making sure that their disease is appropriately treated. If I asked your cardiologist at your hospital, of your heart failure patients, how many of the patients that have heart failure are on goal-directed medical therapy, 3-drug or 4-drug therapy? They would have no idea the percentage, I guarantee it. If I asked you the question, how many patients with atrial fibrillation, it's an arrhythmia disorder, requires a blood thinner. There may be somebody in here who has AFib. It's one of the most common arrhythmia disorders that lead to stroke and heart failure. But if I asked you that and I said, how many patients have atrial fibrillation who have been presented to your hospital in the last 90 days with a bleeding episode, which we know is very frequent, you couldn't answer the question. You can't identify the patients that are requiring treatment because we can actually fix that. We can actually do a procedure to not require you to be on a blood thinner. But you can't answer the question in your current patient population about who those people are. You cannot identify their specific needs. And that's what got me interested because I was asking these questions and we couldn't answer it. And this is where I found the solution. So the last part about this, and I bring it up last, is benchmarking. As much as we don't like to compare ourselves to other programs, it's really important to know how you stack up. Because if you ask a physician, especially a CT surgeon, how we are, we're the best. This is the best. You're not getting it anywhere else until you start to compare it to other programs. You're like, wait a minute, we're actually not? Wait, you're doing this better than us? How is that possible? But it drives your performance and it also allows you to leverage best practices from other programs. So when you benchmark yourself against other sites, CardioCare is able to do that in the back end so you can see how you are doing in terms of your treatment. One of the things that has helped save a lot of lives is, door to balloon time when it comes to heart attacks. It's something, I don't know if anybody here is involved in tracking that metric, but you do track that at your hospital. Door to balloon time is an important thing because what that is, it's identification to treatment. And they've built whole systems around that. They spent millions and millions of dollars to build systems just for that. This system does that for every disease. It tells you when you identified it, when they got referred to the right treatment, and when you treated it. So when you start to benchmark yourself against that, we begin to see how good we are. And aortic valve stenosis is one of the diseases that now we can intervene on it with very low risk, with significant reward. And so we're allowed to benchmark ourselves against each other. The other thing we benchmark against is how is your cardiologist or your surgeons doing in terms of managing the patients? Where are these patients that are sick? Who has those patients, right? And so you can look at everybody in the practice and say, oh, here we go. Here is a physician, and it's not good or bad, but has a lot of patients in this category. Maybe we need to go and discuss why we are not referring these patients that have class 1 indications for treatment. You can also look at your sonographers. When's the last time your program ever looked at how good your sonographers are at actually identifying disease? We just assume every echo is done and it's equivalent. It's not. What we found at our program is that we had some sonographers that were excellent at identifying disease and other ones that weren't. And so what did we do? We went back and we trained the ones that weren't up to the benchmark level of what we have at our program, and we re-educated them. there's no way you would have the ability to have that insight. And it's instant insight. You're not spending time digging through data. It's on a dashboard in front of you. So here is our metrics at our hospital. The data is through 25. It goes back to 2020, so before we started evaluating this. So we're able to look at national average for echo diagnosis rate, and at most programs it's about 1.3%. We're still following a little short. Some of that is because we are treating a lot of the disease, so we have less of it, so we're not seeing as much. But you're able to benchmark how you're doing across compared to the nation in terms of diagnosis rate. We're a little low. You're able to compare your 90-day evaluation rate, right? And this is just for aortic valve stenosis, but this is the start of your door to balloon time for coronary disease. This is your 90-day evaluation rate, and really you can look at your 90-day treatment rate here. Oops. 90-day treatment rate. So now we're seeing what our 90-day treatment rate is. And this number for us, we've gone in and said, wow, 48% is not good. We're actually much higher than that. But when you take our old data on how we were doing, we weren't doing very well. So we're still including some of that data here. But you can see how we compare it to the national average. And these are patients that have class 1 indications for severe aortic valve stenosis. And there's one other cardiologist in the room, and he'll tell you the mortality rate of aortic valve stenosis, and we're just targeting one disease process in this talk. If you have severe aortic valve stenosis with any symptoms, that survival rate at 2 years is less than 50%. So at our program specifically, what's the current opportunity of where we are at? We currently have about 62 patients meeting class 1 indications that we are evaluating now. And we just pulled some of this data. So we have an opportunity right now to close that gap and treat these patients, and we're currently doing it. We're able to identify where there is prolonged wait time, and we can decide if we want to intervene or if we want to watch and wait, right? So we're able to make those decisions. One of the questions that really was the core to me moving forward and now using this is how many patients are dying with a treatable disease? It is something that you want to know, but you don't want to know, because it shows you where you could have had an impact and somebody else would be here today, somebody else's family members here. And it's a really hard topic to bring up, And when we started, we looked at this, and again, you have to parse out some of this data, but the mortality rate here was 14% of people who had severe AS. Now, they may have had other diseases going on, there may have been some other things, but that is a very high mortality rate when we started. And now we've driven that down because we're identifying it. At your programs, I guarantee you, if you were benchmarked against this, it's very, very similar. You just don't have the data to show what's actually happening in your health system. So going from a death slide to a very positive slide is a tough translation, but I'll tell you, you have to look at that data to understand why you're doing this and what the difference is going to be. And so now I'll tell you our mortality rate is almost 0% for people waiting for severe aortic valve stenosis. Our revenues at our program, we have grown tremendously. I told you we're doing about 290 aortic valve procedures now in our program. The first year we had this implemented, we saw 159% return on our value. So we were able to do about 25 additional procedures just from that. So there's 25 people now treated in 24. In 2025, we were able to bump that to 40. Through Q1, we were already sitting very similar numbers here. And these are people that are being managed by physicians at a very well-respected cardiology practice, very excellent doctors being managed. We've still already found 9 in the first quarter that needed to be treated. There's just too many patients out there for us to manage. And for us, over the whole time we've been using CardioCare, 13% of all the patients we've treated with aortic valve disease have been from identification through the system. So what does that mean to you and your program? So yes, you're saving lives, yes, you're intervening, but what it gives you guys, and this is the executive slide that the physicians don't really get, because they're just like, hey, are there more patients to do? Are there more patients to do? Well, yes, so this is an example of our program. I pulled some data from our program. So we have that 62, and it's 63 on this slide, depending on when we pulled the data, of patients with AS, right? If we're able to convert 10 of those patients that we diagnose with severe AS, right, into this, we can begin to look at what the contribution margin is of all the different disease states that are currently sitting in your health practice. So you're going to go to your executive meetings, there's no physicians there never are, and you're like, hey, what's the pro forma on our cardiovascular center? And you're like, well, I think we can probably do this many cases. And you're like, based on what data? Well, last year we did this, so we're going to predictably put an assumption of a 3% growth. That's terrible. That's not accurate at all. I mean, you do it because you need to give them a number for an estimate on a budget. Like, hey, we're thinking about expanding into more office space, and we want to go show that we can invest to build, more cardiovascular suites. We got a donor that wants to donate. They want their name on something, but like, do we even have the need for it? It's very hard to answer that question unless you can go into your health system and identify what actually needs to be treated. And these are actual numbers for my patients currently. So we've got 63 that need aortic valve treatment. We've got 42 with severe MR. We've got 927 that need AICDs. These are defibrillators. These are people who have heart failure and have a risk for having ventricular arrhythmias that will cause death, right? 927 just sitting there. I've got 7,900 patients right now that have class 1 indications for ablation therapy. And I've got 1,000, it's actually sometimes 1,600, it was up to 1,600, that need their left atrial appendage. So that story I told you about the bleed, well, we can do a procedure to prevent them from bleeding, from taking them off blood thinner. I've got 1,000 of them sitting there now. I have no room to do this. I've got 2 EPs that are functioning for us. I've got a few interventional cardiologists. We can't, it's almost overwhelming to see what you need to do to your patients and what you're missing. So you have to target specific metrics and start specific goals. But what this has allowed us to do, we're building 80,000 square feet of new office space. It'll be opened in the summer of 27. We're building 7 new cardiovascular suites so we can begin treating these patients, right? Because we don't have the room. We just don't. But if you're going to go to your hospital and you're going to say, hey, I want to build these things because everybody likes to be bigger and better than the guy next to them and have new stuff, now you can actually back it up financially. So a very conservative approach, and I just put these numbers together, very small pull-through, you're pulling an extra $1.53 million just to your total bottom line margin here. So it gives you upstream early detection. You can begin to secure the funds and resources for expansion, right? And then you can really prioritize what areas you need to treat in, because you're going to have to go out and recruit physicians, and there's not a lot of them out there, right? There's just not a lot that are doing this higher level type of treatment that you need. So now you can put a plan together to go begin recruiting, because you know that you have this many patients, and unfortunately this number continues to grow. You're working through it and you're like, there's more patients, there's more patients, there's more patients. And at some of your health systems that have 10 or 15 or 20 or 100 hospitals, these numbers, you're going to need a wider column to fit them in. So my experience initiating CardioCare at my program, it took about 18 months, and it had nothing to do with the company. They're available. The connections, the APIs, everything you need to do it is fine. My biggest struggle was with my hospital administrations buying into why we need this. And now they're begging me to keep it and keep working through it because they see the value. But it was very difficult for me to articulate to them why this is good, right? Clearly from a clinical benefit, yes. But they were very focused on the finances. Well, it's going to cost me X amount of money. And I said, I can tell you right now from the cursory survey that we did with the software, we have plenty of patients to do, And I said, if we just found 15 patients, it'll more than pay for the software in and of itself. And it's actually less than that now. It's actually about 9 patients for us to be able to do that. Because one of the things that has come out of this operational efficiency is also, we've taken a similar approach to looking at what the cost is and how we can better be more efficient during our cases. And so now our profit margin on a standard TAVR procedure is anywhere between 10 and 15,000. That's the bottom line. So, for me, just looking at aortic valves, if I put in 8 TAVRs, more than covers any cost that I would spend. And my point to them was also FTE optimization. When you have a system that is doing this and screening and looking at all these patients for you, you don't need to hire another FTE. They're already talking about in the AI space, look at Facebook, how many people did they lay off? And I'm not suggesting you need to lay off people. What I'm suggesting is you can direct those FTEs to other areas that are actually directly delivering clinical care versus just doing administrative work, because now you have something that can work in the background to do a lot of that administrative work. And so for us, we've been able to have FTE optimization. One of the things we struggled with at our program was on the IT side of healthcare. It can be very challenging for them to communicate to software companies. And the software companies are very well equipped to handle this, but I actually had to bring somebody down to talk to my IT department that CardioCare brought in with them to help explain to them what they're doing and what we need them to do, because they weren't aware. Because again, they're inundated with all of these tech solutions and they're not staffed to accommodate that. So I think for you, in terms of your program, thinking about and evaluating how adoption of something like this in your program would have a massive impact. And you're gonna need to have physicians in the room. I really like what he said about having physicians in the conversation. You need to have physicians in the conversation, because the minute they see something like this, they're gonna do what I did and said, when does it start? When can we use it? So if there's questions, I'm happy to answer more questions about it, why I use it, what I'm using it for. I'm happy to talk about, I know a lot of your health systems. I looked at the list. I know a lot of the surgeons there. I know a lot of the cardiologists. It's a small community. I found out last night because we have a conference, the largest cardiac surgery conference in the world. AATS is down in Chicago at the conference center. So I was there last night talking, and I found out over dinner and some drinks, people start telling stories that there's the same number of cardiac surgeons as there are Navy SEALs. I had no idea. I had no idea that. So we know everybody at your programs. Usually it's a very small community of us. We have a little bit of time. I'm happy to answer questions if you guys have anything specific. Yeah, go ahead.
You kind of addressed it, but it's the flip side of this. I see the financial benefit. I also see the volume increase that could happen where you're now identifying patients. But what happens when the demand exceeds the resources? Now you know there's a bunch of patients. I mean, it's better to know than not to know. But I have this other side of me that just says, now I know you can't take care of it still, because we haven't built what needed to be built to support what I now know. And maybe that's not fair, because ultimately I understand the financial piece of this, but I struggle with the other side a little bit, because we can't meet that demand.
That's what drives, I'll tell you, that's what should drive urgency in all of us. I mean, that's why I'm going back to work tomorrow, because there's more patients to treat. That's what we signed up to do. So having that information, yes, we struggle with that same thing. We're only focusing on one area of our cardiovascular program to improve, and now we've got that better, and now we're moving on to the next. That means, did we miss patients that we could have treated and probably saved their lives? For sure. Would we have missed them anyways? Yes, but now we know. And now that drives urgency. But you can only work at the speed you can work. And it doesn't change the end of the outcome. It just hopefully brings everybody at your program, administration and the providers, into the room and says, we have a problem to address. And that's a good place to start, because one, clinicians want to treat the patients. That's why we're here. Two, you guys want to make sure your health systems grow. You want to make sure there's revenue there. You have certain obligations. If you're a publicly traded company, Tenet, HCA, any of those, you have shareholders to report to. You have a job to do, right, as well. And this allows you to do all of that. But that question, it makes it exciting to wake up in the morning, because there's an urgency to go treat patients. What else? I know there's more. Oh, yeah.
Out of the data that you're seeing, are you able to do it demographically? Are you finding male versus female, age?
All of it.
All of that?
All of it. They can all be published. It can all be researched. I mean, you have to remember, you have 7.2 million echoes on patients. We have all that data. So the amount of data mining and questions that you can answer on a national level, if we had, there's 5,500 hospitals, maybe 350 million people in the country. If you were able to get half of those, think about the amount of information you could provide back, both publicly and privately, to treat these patients. The public health systems have none of this data. They have no idea what's going on, but you would have that data. And so now you have insight into 7.2 million. Imagine if it was 200 million. Imagine what you would know. So those demographic questions that can never be answered in a public health setting could now be answered by simple software. And it's coming. The adoption just needs to be faster.
So as a researcher, that would give you innumerable points of interest.
You could spend an entire career in one of these sections doing research and figuring out how you do throughput. Because now, one of the things that, and being an engineer, we're driven by efficiency. And so one of the things that has come out of this is, because of the need, it says, how do we be more efficient? How do we treat more of these patients? So now we've gone from doing 3 TAVRs in a day by like 5 o'clock when I started. We can do 8 by 2 o'clock. So what that allowed us to do is, who's a Six Sigma black belt? Yeah, I know you're in here. It's all administrators. Yeah, all right, that's fine. All right. Any green belts? Probably not. I don't know. Oh, we got a green belt. Working on the black belt. Good. So like this is Six Sigma black belt. It's built for you because now you say, here's the problem. How do I be more efficient with these patients and bring them through? And so when we implemented those, we don't have a Six Sigma. They won't even hire one in our hospital. So I ended up doing that. But we went from 3 to now 8 in a day. And it required a lot of changes, but now we can do 8 by 2 o'clock. So now we have 8. So now I said, yeah, I can do 8 every Wednesday. So that's a lot of patients we can now do. We can do almost 400 in a year. So now I can address the capacity issue, right? Now I can go tackle the other problems, which are much bigger, which is we don't have enough space to do these cases, right? We also don't have enough nurses who can take care of them. Yeah.
Just going to follow up on the gentleman's question because that's something that we come across as well. But before I ask that question, how much of your time is spent with the company versus doing surgery? So I can ask
I do 99.5% surgery. And yeah.
The same thing important because as a proceduralist myself, the same thing is what we see in the lung cancer space. Right? So I do a lot of robotics, and lung cancer is the biggest killer, as we all know. So all these AI tools that you have, CardioCare, similarly are present along this.
Yes.
The exact point that you mentioned is the exact pain point, and I don't think that the answer is just that, oh, I'm going to wake up in the morning doing my procedures. I am also going back to work tonight, going back home and working tomorrow, but I already have a full schedule. I already have a full procedure log for the next few weeks. The 20 patients that you're extra adding with your...
It's not about that, though. Yeah.
That is a bottleneck, right? You're fixing one bottleneck, but you're opening another one. Because I see the same thing in lung cancer.
Sure.
Every single AI company is like, oh, every nodule more than 8 millimeter, which I really care about, that I could potentially biopsy safely, effectively, and make sure. But the ground reality is that 80% is not cancer. But to have to get that nodule detected, sure, that's a new bottleneck. That how will you determine how you will see this? You're already full in the next few weeks or months. It's going to open up a new bottleneck. So what's the solution for that? Because cardiac.
It's not you or me. It's not you or me. That's what I'm saying. The urgency I'm describing is an excitement to get up and go do work. You can't put more on your schedule because of the burnout. But the reason I'm at this talk, I'm not giving this talk to the bunch of the surgeons because they're willing and able to do the work and they're just down the street. But I'm here talking to executives today because they have to make the decision on what that takes to be able to treat those. You need more space, you need more resources, you need more physicians. It goes back to how you're even training physicians and you're not training enough. So how do we go bring more through? So like what you get out of this goes back to your question. It's more than just delivering care and treating patients. It's actually transforming how we do healthcare in this country, and it brings everybody in the room. But in order to even have that conversation, you have to identify the problem. And so this is identifying that. It did it in the lung cancer space. I mean, we're extremely busy doing lung cancer surgery. Our numbers are way up, doing robotic bronch tagging and then doing a robotic surgery to respect the, yeah. But like, I don't need to do more. I've done so many surgeries in my life. Like, I don't feel like I need to do more. I enjoy it, but you have these patients that need to be treated. And we really focus on the disease that has the most impact in terms of life expectancy and prolongation of life. There's a lot of things we could treat that doesn't have a huge impact, but everything I'm talking about today has massive impact factor. We're not even getting down to things that have slightly lower impacts. These are life-saving things that can be done now that prolong life, that if you don't do it, within 2 years, these people are dead. So, yeah.
Let's say, as an administrator and former cath lab clinician,
Oh,
I
you-
build TAVR programs.
You know. Yeah, I know.
To build TAVR program with some actual data.
Yeah.
I think we use a lot of, I used to do, or I could have done 10 of these for my office cases, and that's
Sure.
really educated all of our performance. But for us, this kind of stuff ends up helping educate our community health needs assessment, helps us figure out how many patients we have that we're not able to treat, and then gives us kind of the insight that we can go and build onto the program and invest in other ways in the program. So I think without data, and most, like the TAVR world doesn't have a lot of data.
Nope. None.
Yeah, we're still kind of shooting in the dark of, I had to send 4 patients to this other place, and then, I've got 10 patients waiting, and whatever, and it's all just kind of word of mouth.
It is.
Where we actually have some data, and I think this would be great. And I think I probably worked with a couple of your colleagues for USC
Oh.
surgery over at our hospital.
Oh, you are? Which hospital?
Cash hours over
Christian Cash. Oh my God. Don't tell any stories. We can't talk stories here about me and Cash. He trained me. Him and I were together at LA County. We ran LA County heart surgery together for like 2 years in training. So yeah, there's some stories out of that. Yeah.
Yeah, very good talk. Thank you very similar for nodule. We end up using the ION program.
Yeah.
The ION program, a lot of
Yep.
whatever nonsense. Question here is, can you describe the team that uses this program? Because what we learned through the experience with Eon is the platform is fantastic. It does everything that it's supposed to do. But if you don't have the supporting staff, it doesn't really work for you.
Good question. So we probably spent 2 years figuring that out and really identifying what's ideal. You have to have a physician champion on all of those. Goes back to your point in your talk. You know, if you're doing these things without a physician in the room, not going to work. So you have to identify a physician champion to oversee this initially. We currently are structured. We have, in our TAVR program, we have nurses called valve clinic coordinators, and they coordinate the care for all these patients. So their job is to work them up from pre-op all the way through the treatment and all the follow-up and registry data. So that's how they run our TAVR program. And so we've taken one of our valve clinic coordinators and moved them over into becoming a champion nurse over this. So their job is to work in this every day, all day. And I think that's how the current programs I know that are expanding, that's how they have it. So they've got a physician champion, and then they usually have a nurse or an APP that is overseeing a lot of this data, because it requires somebody to be in it almost every day, keeping up with it, right? Just in one section, needing one person to oversee that. So that's probably the ideal structure. Is as a surgeon, it's unique for me to do it because most people are cardiologists, but it just was the perfect fit for what I needed to grow our program. So you're going to need one of those champions, and then you're going to need a nurse champion over it who's going to be working in this all day. And then we usually have scheduled meetings once a week to review this. We present it at a conference. We look at that data. But there's a lot of communication back and forth between me and that nurse about where we are in the workup. Now, she does most of the work. She does all of that things, and we build protocols of what's being done, but she's working in it. So the next step of this iteration, and I'll share it even though it's early stage, so we are in the process of now allowing CardioCare to begin pushing certain orders back into Epic. So patients that have, for example, we're staying just in the AS, aortic valve stenosis category, patients that have moderate AS, right, that may have some clinical indications of progression, they need to have follow-up echoes at certain frequencies so that we don't miss these patients when they begin to go into severe AS. Because at the point that they convert into severe AS or retreat, there's already oftentimes been structural changes to the myocytes, to your heart, that never come back. You can get fibrosis deposition that never comes back. So you really want to, we're still not optimally treating these patients in this country, and we know that, but we're working in the system and we're working back. We're working from where we are, treating them very severe, to getting to that optimal point where you want to treat a patient before patient harm is done, that optimizes the longevity of the valve you're putting in and the future treatment options. So you want to treat them right before the structural changes of the heart begin to happen. And so what we're doing is we're allowing CardioCare now to push an order back in to reorder echoes on those patients. So now it was a doctor and it was a medical assistant or somebody having to put those orders in and making sure they're done. Now the system is doing that. So the long-term vision of this is this can really run your cardiovascular institution from a screening platform, right? It's not deciding who's getting treatment and who's not. What it's going to do is going to drop out who it thinks needs treatment for you. So you're just picking them up. Oh, needs it, and you're so confident in it, you go back and validate it and say, yep, they need treatment, bring them into clinic. So we're allowing it to now deliver, I don't want to say care, but begin putting orders back in, because then that offloads the physicians from having to order these tests, approve them, click them, all these things that you have as a physician that you have to do that doesn't involve delivering care. It's now doing for us. And now one other piece that I'll share that is early, but we're working on integrating the EKGs into this. And once you integrate that, now you've got a full assessment of the heart in a program. And so what that data is going to add, and it's coming, it's going to be a little while, but a lot of insight, not just into valvular disease or heart failure, but also to coronary disease and other changes of the heart. So it's expanding, but it goes back to your point about there's so many patients to treat. So that's how we have it structured. But again, every hospital system's built a little different. But I guarantee you dedicating one FTE for this is probably going to save you 3 or 4 FTEs of just trying to manage these patients in another way. What else? Oh, yeah, sure, sorry.
Yeah, I kind of dovetail from the
Yeah.
answer. One, what's the patient feedback when something like this?
So patients don't directly see all this, but the minute you talk to them that, hey, I'm being followed by a system that's keeping me on track, they love it. They love it. As a marketing tool, to say that We are clinically, we're observing you at all times. We're watching your heart for you at all times. I mean, patients in cardiology space go home with monitors to monitor their blood pressure that sends, signals back to let them know their heart rate, their blood pressure. They go home with certain monitors for their electrical rhythm that gets monitored by a physician. So this is just one more tool. So patients love it, but it's not a patient-facing product initially. So what else?
Second question is, you mentioned EKGs, which is mostly graph report information. For the echocardiograms that this is trained upon, is it consuming graph report information, or is it reading the text of the report?
It's reading textual reports, so it's reading the numerical part of that, as well as the verbal and written part of that that's in those reports. And what's interesting is that you can pull up a section where you can actually look at what the measured numbers were, and you can then look at what was said about it, and you find discordance. Somebody may call something moderate when there's 2 or 3 markers for severe. So we catch that all the time. And that goes back to just going back to the cardiologist. Hey, what were you seeing here? What were you seeing there? Oh, I didn't quite catch that number. I missed that part. It's actually severe. Okay, we'll send them over. That happens all the time. So.
Your other columns you had up, where you had thousands, right?
Yeah.
7,400.
Yeah.
How do you prioritize that, or how does the system help you prioritize it? And what's
Yeah.
the pair mix like? Because I know, the pair mix can be all over the board.
Yeah, I mean, it just depends on where you're practicing. I mean, for us, we have a lot of Medicare with our age range, but you could look at that. But I don't think the payer mix necessarily goes into our decision making when we treat a patient. But what you would do is you would take those patients, and then you'd begin to look at the patients that are beginning to have structural changes, so dilation of their atrium, valvular disease. So there's a lot of components that go into triaging those patients. We currently don't do that in medicine because we don't have a tool to do it. But now you could screen out all the high-risk patients. Like, hey, I want to treat heart failure in these patients, but which ones are coming back to the hospital actually having a problem? Oh, here's the ones that have been back in the last 90 days. That's your triage list, right? Because they're routinely coming back. You're getting readmissions. And so now you can identify the problem ones and figure out what we're doing. So what we did is we opened up an entire heart failure clinic. So rather than come back to the hospital, sometimes these patients have fluid buildup because their heart's not functioning well. We can bring them in, get them IV diuretic therapy, and not get admitted or go to the ER. So now we're finding the problems, the patients that have disease that aren't fully optimized, and we're sending them to a different pathway to get treated because we've triaged them. Yeah, go ahead.
So once a patient's been identified
Yeah.
with severe AS, and then it's flagged in CardioCare, how do you guys actually operationalize? You chart messaging them? How do you actually build the trust to actually bring them back in?
That's very dependent on how your practice is set up. For us, because the majority of our cardiologists work in a similar system to us, we can directly reach out to them. So that's either my chart, usually it's a text message, phone call, very simple, boom. But we have whole outreach programs that we've built. So places in Pennsylvania, they'll just do mail letters. They'll just mail them. Say, hey, you've got disease, directly to the patient. Say, hey, you got this disease, we want you to come in. Because their echo was done at some outside ER. They don't have a cardiologist, but we've identified it, so we'll do that. So you have a lot of ways to reach out to them. I think it's very specific based on how your practice is built or how your organization is built. If you're in a place like Kaiser or HCA or Tenet where it's just all inbound all together, like you have a really easy way to do that because everybody's connected. So cool. All right. Oh, no more questions?
Thank you very much.
Thank you,
Doc.
guys.
That was
Appreciate it.
it.